Good evening, everyone. Thank you for joining Focus MSF Action Briefing Series. My name is Ji Hyung Bang from the Communications Department of MSF Korea. So first of all, we are providing simultaneous interpretation in Korean and English. So if you need interpretation, please press the interpretation button on the screen. MSF is an international medical aid organization. We operate in areas that are devastated by armed conflict, epidemics, natural disasters, and the areas that lack medical services. We are holding this focus series every quarter. So MSF is the acronym of Médecins Sans Frontières. So MSF is the Doctors Without Borders, just for your information. So we are holding this focus series every quarter to highlight the issues that are often overlooked and underreported. Our goal is to provide an insight into MSF's operation. So we will go through the details during the webinar. The third briefing of the year will revisit a crisis that happened 17 months ago in April last year. This crisis erupted in Sudan. The escalated conflict forced people to flee, and countries quickly evacuated their people in Sudan. The clash between the Sudanese army led by the government and RSF, the rapid support forces, spread across wide areas. So Sudanese people are grappling with repetitive attacks, abuse, and exploitation. It's been a little over 1 year, but the conflict is still ongoing. Housing, medical infrastructure, key infrastructure, and medical facilities have been destroyed. Currently, MSF is operating in Khartoum and Darfur State. Sending the humanitarian aid into the country is difficult because the country is currently isolated. But we are still working in Sudan across Khartoum and Darfur State. So today we'll look into the situation in Sudan, and we would like to welcome McNally, MSF's Humanitarian Assistant Advisor, who recently returned from his work in Sudan. And before he briefs us on the current situation, we will watch a video of MSF International President Christos Christou, followed by his presentation. And if you have any questions during the presentation, please leave them in the Q&A box at the bottom of the screen, and we will answer them during the Q&A session following the presentation as well. And also, we will have a survey after the webinar, and please participate, and we have special gifts for all of you who participate. Okay, without further ado, let's watch the video.
Sudan is one of the worst crises the world has seen for decades. There are extreme levels of suffering across the country, and the needs are growing by the day. Patients are dying due to violence-related injuries and preventable diseases. Children are perishing due to malnutrition. Women from complications during pregnancy or childbirth. There have already been outbreaks of cholera and measles. Vaccines are running out. Yet, the humanitarian response in Sudan is profoundly inadequate. Both warring parties are making it extremely complex. The government of Sudan is deliberately denying permits for humanitarian staff and supplies to move across front lines. In some areas controlled by the Rapid Support Forces, insecurity and harassment of medical staff make the provision of care very difficult. And amid the conflict, health structures are not spared from the violence. Very few are functional today. This is having a devastating impact on the lives of millions of people across the country. Before the war began, more than a year ago, dozens of international organizations were responding across the country. Now, in many of the areas of the country where we work, there are very few other organizations. In some cases, none. For a crisis of this scale, this is unacceptable. It cannot be allowed. This level of international neglect is shocking. Sudan urgently needs a large-scale humanitarian response, safe humanitarian access to all areas of the country, and full respect for international humanitarian law. The civilian population must be protected and assisted as a matter of urgency.
Hello, everyone, and thank you very much for this time. My name is Kyle McNally. I'm a Humanitarian Affairs Advisor, as mentioned. I'm based in our Berlin office. I work for OCA, and I've been supporting Sudan since our emergency response began last year. I spent some time in the east of Sudan last year when we were getting our response going, and then recently just returned from some time in Darfur, which I'll be happy to talk about. But again, thank you to everybody who's joined today and also for the opportunity to talk about Sudan. I'm going to start today just very generally, briefly, but generally about the context overall, because I think it's important to put some of it into perspective. And then I'm going to go through a presentation on an initiative that we launched recently, a report that we published recently on violence throughout the conflict. And then I would like, if we have time, to finish a little bit with a focus on Darfur and the humanitarian context and needs in Darfur, if possible. So thanks again, and thanks ahead to anybody who will have questions, and I'm looking forward to the discussion that comes. So just to start, I think it's important for us to bear in mind the scale and the population figures for Sudan, right? This is a country of 50 million people plus. And there are millions, tens of millions of people in need, with millions already in need prior to this conflict starting, right? There was also more than 1 million refugees hosted in Sudan before this conflict erupted last year. And so you have this really complex crisis, which is somehow the acute nature of the needs is somehow lost in the scale of the crisis as well, because you have protracted needs from people who were already displaced and living there or in need otherwise. And then you have obviously all of the emergent needs that have come from the conflict. So ranging from conflict related trauma to any needs that relate to the destruction of the primary healthcare system, with upwards of 80% of facilities non-operational in many areas. But of course, all of the secondary care, the women, the mother and child care, outbreaks control, the continuation of care for chronic illnesses. I mean, the range and the spectrum of needs is so varied that it becomes almost hard for any one of these crises to somehow break through when the emergency is so large. But yeah, so I think it's good to keep in perspective the scale of the needs. And we were looking at this when we were going through the 1 year, when we approached the 1 year anniversary of the conflict, and how insufficient the humanitarian response had been up until that point. And so part of our attempts to try and answer the question of what we can do more was also to kind of ramp up and increase the way in which we talk about the conflict, with more direct messaging around what needs to be done by other humanitarian agencies, but also around what is causing all of this suffering in the first place. And so that is what motivated the initiative of publishing the violence report, which of course is also in keeping and in line with our principles and what we see as our duty to bear witness. And I want to take a little bit of time just to go through this report. I'm going to share my screen for a presentation, but I will move through it pretty quickly. So I'm going to give a brief overview of our report initiative, which we called A War on People, the Human Cost of Conflict and Violence in Sudan. Can briefly update you on the approach, or give you an overview of the approach that we took, what our focus was, the findings, and what we wanted to convey in the release of the report, and the way in which we went about doing that. So this was the report was now published exactly 1 month ago today. It was preceded by a visit of our international president to the country. This was part of our attempts to get the sufficient level of attention on it, but also to help to mitigate any possible negative repercussions that we would have, any negative reactions. Of course, released in both English and Arabic. A regional press conference and we had a strong focus on regional media in our approach. We don't have to spend a lot of time on this, but for those who are interested, just to say in terms of methodology, even though this was an OCA or an MSF Holland initiative, it was something that all sections working in Sudan contributed to. And we really relied on this being an intersectional initiative from all MSF sections. We, of course, included a lot of our data from working in Al Now, which I'll talk about in just a second. But when we think about issues like sexual violence, this is something that we relied on our missions in Chad for, and in particular the OCG mission in Chad, who had very strong data on this. And then, of course, in addition to the medical data, this is complemented by qualitative testimonies and accounts that we received from both patients and staff. For those who are interested, one of the major points of focus internally in the preparation of this has been, how do we handle responsibility and how do we attribute responsibility? This is always one of the questions that we have to answer when we embark on a kind of bearing witness or speaking out initiative. Suffice to say that we don't also claim to know or be in a position to say who is the most guilty on XYZ or on any given issue. And so that isn't also our attempt. We really do this analysis based off of the data that comes to us by virtue of our medical programs and also by who we were speaking to because of our program. So we know that we're not kind of war crimes investigators able to make determinations about kind of levels of guilt, and that's not the intention, but nonetheless we do our due diligence in the methodology and analysis of all of that. The key findings and messages coming out of the report are probably not going to be a surprise to this audience, right? One of the first things we wanted to get across is that this is still happening, right? When you look at the levels of trauma-related injuries and conflict-related injuries that we see, this is not something that was the early days of the war. This is still happening right now. And that's something that we need, I think, everybody to understand, that this is still ongoing. And in some cases, it's getting much worse, not better. As mentioned in Christos's video, another major point that we need to emphasize is that healthcare is in no way spared, that healthcare workers, healthcare facilities are very much under attack, very much targeted or otherwise disregarded and not protected in the way that the warring parties are conducting this conflict. The kinds of violence that civilians encounter and experience really varies. It ranges from the conflict-related trauma, gunshot wounds, blast-related injuries, but it also includes a lot of injuries that are experienced during or on the path of displacement. So whether it's violence in the home, oftentimes sexual violence being linked to this and displacement. It can also be harassment, physical abuse. We've had a great deal of number of patients coming through who were detained and tortured during that period of detention. And then, of course, there is the kind of chronic health conditions that are going to be exacerbated by these experiences. There's the mental health trauma that people go through as a result. So the types of violence that we encounter, again, run a pretty broad spectrum, and that we see that patients have experienced. And needless to say, this takes us a huge toll on the health and well-being for people, which is a big problem when the healthcare system is completely destroyed, right? We won't spend a ton of time on these, but just to say briefly, to put some of it in perspective, this is just one hospital. In just one hospital in less than a year, we had more than 6,000 conflict-related trauma patients, right? And when we tried to dig deeper into that data, we did a kind of spot check for the month of March. We saw that at least 30% were women and children under the age of 10, right? Just underscoring that this is kind of generalized across the population. This is not something that is affecting people who are involved only in the fight or military aged males. So we see huge numbers, and like I was saying, this is just one hospital, right? We don't know what it's like, but we assume that it has to be similar in other areas of active fighting. I mentioned that we see particular heinous forms of violence when it comes to displacement that people experience. So this is in the home. Just leaving Darfur, you see the kind of remnants of localities and villages burned throughout, right? And this was a huge practice. I mentioned cases of torture, SV, which we'll talk a bit more about in a bit. And of course, the impact that this has on people's healthcare. As I mentioned, between 70 and sometimes even 80% of facilities non-functional in many of the places that we're working. So of course, in concluding an initiative or in a report such as this, we have a number of calls to action. In the first instance, we focus these calls to the warring parties themselves, really focused around the need to restore civilian protection or enforce it for the first time. And notably, we included in these calls for accountability. This is something that can be a kind of contested issue within MSF communications, I think as many here will know. But notably, we've included that call here, targeted calls to the regional or more states that are more involved in this, to specific UN agencies, as well as regional governance bodies, and of course, the kind of humanitarian community more broadly. We're still in the kind of rollout of this. This was a month ago now. Our hope is, and our planning, just for interest for folks, is that we can keep somehow enough attention on this or use this as a device to get us to the General Assembly, which is going to be the third week of September. So to ensure that we have enough attention, and especially on the violence that people are suffering through as we go into the General Assembly. Yeah, and I mentioned kind of regional targets, audiences. So I think I'm going to stop sharing my screen now. And what I'd like to do with a bit of time left is focus just briefly on my time specifically in Darfur to emphasize the needs and the context, and one of the areas that has been most heavily affected by the fighting that this report talks about and that we're trying to address. But to give you an idea of what it looks like more locally for folks. So Niala, South Darfur was the second largest city in the country before this conflict started, behind Khartoum. So this is a major this is a major city in a country of 50 million. It's quite large. And Niala and the surrounding areas before the conflict reportedly hosted up to 6 million people, with 3 million in the city itself. Now they're saying the whole surrounding area might include 3, with like 1.5 or, give or take within the city center. But of course, realistic estimates are really hard to go by. But this is still a really sizable city, even given the circumstances and the conflict that has taken place. And we are the only provider, for example, of cesarean births, or anybody who has a kind of complicated delivery. And there's really only 2 non-private hospitals functioning at all for this entire city, including also then huge IDP camps that exist in the surrounding areas, like including upwards of like 200,000 people in one of the larger camps. So you have nobody responding in this area, which is hugely and still densely populated with large numbers of people in need. And MSF continues to be the only international organization responding with international staff and also with regular supply reaching. We still don't see any UN agencies arriving to Niala, and the INGOs that are present have not sent any international staff or supplies since the beginning of the conflict. So we see no response coming. The north part of the city is almost completely destroyed by the conflict, and hospitals, water systems, any kind of infrastructure, none of its recovery is being supported at the moment. So our focus has been really very focused on secondary care, maternal child care. But given the scale of needs and the lack of a coordinated response coming, the conditions are still very challenging, even in the areas that we're focused on. And to put it in perspective, when we opened emergency care for pediatrics, we had 20% child mortality in our emergency room after the first 6 weeks of operating. So that's 20% of kids coming in aren't leaving into the ER. And then we had very high levels of maternal mortality, multiple maternal deaths on a weekly basis, which we're still making sense of the numbers, but it seems to outpace the highest numbers of maternal deaths I've seen in any MSF program personally. And then this pales in comparison to what we hear from communities, right? Because we're only in these limited facilities. What we hear from the sheikhs in this large camp nearby is that there were, in the month of June, I was told by him that there was more than 80 maternal deaths alone in the camp, right? So this is a mother and child health crisis that's unfolding in Darfur that is going somehow unnoticed, and certainly not enough attention even where it's known. And an unfortunate feature of this is also relates to sexual violence, which I want to spend a moment talking about because it's such an important aspect of sexual and reproductive health and women's care in generally, and because SV has been a feature of the fighting in the way that warring parties conduct these hostilities. We have seen significant sexual violence. But one of the most concerning things that we see in our data is not actually what we see in the violence data, but it's what we don't see. It's what's missing in our data. So to give you an example, in the report that maybe you'll see or look at, you'll see that in Chad, when we analyzed our sexual violence data, we had more than 135 case files that we analyzed, and more than around 90% armed actor perpetrators, right? So this is what we expect to see in a situation like that there would be a huge number of armed actor perpetrators and a pretty even distribution of adult child, what we'd expect. When we interrogate our data in Niala, we see less than 5% armed actor perpetrators. But something equally curious, 90% of our patients are under the age of 18, and more than 20% are under the age of 10. So when you start looking at it closely enough, what you realize is that on one hand, we have a child rape crisis going on in Niala, South Darfur, where we have insane levels of children coming in, survivors of sexual violence in need of care. But it also means that we're missing the vast majority of other survivors, of adult women or women over the age of 18 in particular, who then aren't presenting for care because of any number of barriers that they may face. Because of course we know in these situations, there's going to be cases that don't reach us. But in this situation, it's really striking to see just how much we're missing. So I think in short, just to say there's a lot of work still left to do, both for MSF and for the sector. We've had some recent changes. There's some recent announcements coming from the government of Sudan that a border crossing point will be open. This is good news, but we know it's going to be much more complicated, and we know that there's still a very long road ahead. And it's going to require significantly increased but also sustained attention from the international community and from UN agencies, and really from anybody who has kind of levers on power and influence within the UN system right now. And so I want to finish by again thanking you for the attention on this topic, because I do think that this is going to be what we need to continue doing. We need to continue talking about Sudan and ensuring that there is sufficient focus on it globally overall. So very grateful for the time and happy to answer any questions that there may be.
Yes, Kyle, thank you very much for that presentation. And we did hear very loud and clear what was happening on the ground. think at MSF, we do have a report that was released to depict the situation on Sudan, the war on people, and it has been shared in our chat room for the participants' reference as well, and it is also available in Korean. I think we are covering a very descriptively what's happening, the atrocities in Sudan. So if you have any interest or would like to learn more about what's happening there, please refer to this report. We did receive some questions beforehand, so we do want to go over some of the questions. So I understand that MSF has been working in Sudan since 1979. As an activist on the ground, how much has the situation deteriorated over the past year or so? Of course, we do hear what has happened in the local media, but we hear it's actually at its worst point, and it is a humanitarian crisis. What's the situation like now, and how do you expect the situation in Sudan to change in the coming months? Would you have a response to that?
Yeah, it's a good question. It's one that I'm probably not best placed to answer because I wasn't there prior to this, so I can't speak to, I can't give you my personal impressions of how things have changed over the long history we've been there. But talking to people, they do talk about that, right? Like people talk about how this feels like the early 2000s. You have people talk, mention that. I can put it in perspective to other crises that I've been in. Like in terms of conflicts that I've worked in, I haven't seen this level of destruction, like in the north half of Nyala. I haven't seen that level of destruction since northern Sri Lanka is the only point of comparison that I could make at the end of their civil war, where it's just everything, where it feels like it will be faster for the area to be buried in sand than it will be to recover. When you look at it, it's hard to imagine this level of devastation somehow being repaired and recovered. It's very daunting when you look at that level of destruction. So again, I don't know how that compares to the past in Sudan specifically, but I think that people feel like we have gone through a big kind of rewind to what it was like in the past. What I might say as a point of comparison and kind of underlining the concern is that it is worse now than in the early escalation period, which is something really striking, right? It's not getting better. Like in some areas, of course, where fighting has stopped, you see some kind of like there's a little bit more stability for people, but services aren't returning. Infrastructure is not being repaired. So hospitals aren't coming back online. The municipal water supply systems aren't being repaired. So all of that has a kind of cumulative effect in terms of the needs that it will generate also. But then in the way that the conflict is conducted, like that's also getting worse in many respects, right? We see, and there was a question also in the Q&A box here about the attacks on medical workers. This is part of it. This is one of the ways in which it's getting worse. Like it's not MSF Holland or OCA specifically, but in North Darfur, it was like in 1 month period, there was like more than 10 times hospitals were attacked in these latest escalations around El Fasher, right? So we see this is a huge part of how it's getting worse. Again, I know we're getting further away from comparing this to the 70s or 80s, but if we're making any comparisons, for me, it's really striking the fact that the situation is even worse now than it was in the early escalation period of the war.
Yes. I think if we look at the situation now, the prolonged situation in Sudan, the best way to try to put a stop to this or bring an end to this is to end the war. It does seem that that's the best option that we have. In order to end the war, has MSF thought about any ways that you can support this initiative to stop the war fundamentally? course, we provide medical support and take care of the people who are injured from the war, but are there any fundamental points that we're trying to work on to stop the war itself?
So no, and I'm going to say something that may be rather controversial given the question or the framing of it, which is that, and I really hope we don't. I think it's really important we don't start doing that. Not because because I agree with your assessment, right? The war is what is kind of behind a lot of this the suffering that we're addressing. Nonetheless, this is I think that this of course this is a much bigger discussion than only Sudan. But we see this type of language really coming from the UN, where they say we need a ceasefire, we have to silence the guns. We even had the country director from UNICEF saying we have to silence the guns. We have vaccines that we need to use, but that can't happen until there's a ceasefire. And that's fundamentally not true. We know we can run vaccination campaigns during fighting, and we know we have to if we're going to prevent outbreaks. And so while, of course, I'm very personally sympathetic to the positions and towards ceasefire and peace talks, as a medical humanitarian organization, it hurts us to focus on it because it ultimately undermines the norms and the obligations that exist for us to be able to treat people during active fighting, right? There's also a whole bunch of international humanitarian law that says that people are protected if they're wounded, but also that healthcare workers have a right to then they need to be able to provide care and safety, that these are protected spaces and protected people, right? And that protection needs to be respected during fighting. And when the sector gives up on that and immediately just says, oh, we have to have a ceasefire in order to operate, we've given up on the principle of distinction, right? We've given up on the idea that warring parties are going to distinguish between civilians and combatant. And that means that we're hurting and undermining civilian protection more broadly. Because and we're creating this kind of maximalist position that the only way we can operate is if you stop fighting, and they're not going to stop fighting anytime soon, right? So it is not neutral most of the time to advocate for ceasefire, because a ceasefire naturally, if it locks in the conflict dynamics, then it gives advantage to the party with the initiative, right? So imagine, and but in certain places where the geopolitics are so slanted, then we don't see this as clearly, right? Like in Gaza, we don't find it as problematic. But imagine, conversely, if we were to be pushing for a ceasefire in Ukraine, like we would be kind of ousted by the kind of Ukrainian solidarity communities, because of course we can't tell them not to fight and that they should be accepting a ceasefire. So on the one hand, I think ceasefire positions are rarely principled, but also they're rarely strategic, because and right now is a perfect example when you have the UN system saying we need a ceasefire, when you have one of the warring parties saying we are not going to participate in your ceasefire talks. We will not participate in them. So that means that you have to be able to operate and advocate for yourself short of that being achieved, right? And even though it comes from a good place, it ultimately undermines norms around access and civilian protection.
So my next question is that the most MSF is trying to support everyone beyond the religion, beyond ethnic background or political beliefs. So I think you explained well about the neutrality. So you mentioned that we have responsibility to provide medical care even during active conflict. You did mention during the presentation there are many conflicted areas, and unfortunately, there are attacks on healthcare facilities not only in Sudan but in many conflicted areas. So it must be very difficult to operate in such condition. It must be difficult to work in such situation. And I think, Kyle, you probably have experienced that as well. So I wonder if the safety of the activists are protected or guaranteed.
Yeah, so it's a very good and important question. Certainly, safety is never guaranteed, right? I don't think in these types of it would be irresponsible to ever think that it's guaranteed. But we do have, of course, really um, very kind of stringent kind of security management protocols and practices where you try to minimize and mitigate your risk down to as close to zero as possible, but it's always non-zero, right? So no, you can't guarantee it, but you do a number of things. Obviously, a big part of that is our engagement with warring parties. So deconflicting with the warring parties themselves. It has to do with how we operate and operating with a kind of transparency in the way that we communicate with them, but also in the way that we communicate about our activities and communicate to the broader movement. I think that's the kind of most important element of keeping teams safe. It's also in the care that we provide. Like medical care is essential in these situations, right? So it's making sure that we're also like there also needs to be sufficient levels of awareness around what we're doing because that's also the value that we're adding into these places. I mean, in these situations like Al Fasher and North Darfur, you see it just gets completely out of hand, right? Where hospitals are just being shelled or bombed on a regular basis. And so, needless to say, I mean, we've been focused on it from the beginning, but we're also trying to make like another big push on it. So we're in the middle of what we call like a POEM campaign, like a protection of medical mission campaign. So this is working with it's like having more visibility materials, brochures that you're passing out at checkpoints that you're putting around. It's trying to reinforce no gun policies around compounds, more sensitization around IHL and obligations at checkpoints into warring parties, trying to get other actors like Geneva Call and Red Cross to do more sensitization and training to fighters around IHL obligations. But I think it's one of those things that because you never mitigate your risk down to zero, then you never stop either, right? Like this is an ongoing thing that you have to constantly be trying to improve. Like you've never reached the finish line on.
So I understand the activists are running to the areas that needs help. And I wonder, it seems like there's some aid that is ready, but because of the blockage of the borders, the shipments cannot go through the borders. So I wonder if the situation is still the case. And regarding medical supplies, what happens if the medical facilities or the MSF operations lack any of the supplies? How do you deal with it? And there's another question that is along this line, who just asked. So it seems like you have restricted or limited resources as you work in Sudan. Do you have any priority? What is the priority principle that you apply in terms of providing this help in Sudan?
Yeah, good questions. So supply is a really complicated issue. We could spend like the next several hours talking about it. But put simply, right, there's two ways that supply has to reach into difficult areas, either cross line or cross border. It has to cross a front line where there's fighting, or it has to cross an international border. And there's blockages on both sides of this, right? So both cross line is really stopped up by governmental obstruction as well as RSF obstruction in some cases, which now seems to be opening up. But that's something that we have to watch also. Everybody assumes that the kind of bureaucratic administrative impediments are usually governmental, and they often are, but it's not that RSF doesn't also impede bureaucratically. They also do, which is we get this from all sides. So that's cross line. And similarly, the government basically has, they kind of over the last many months have systematically restricted aid that goes into non-government controlled areas by not letting it move cross line, right? So, and then cross border, they have said that the UN system and the aid system must only use this one border crossing point called TNIT, which means that once you, and it's because this is where you move into SAF or government controlled territory, right? And then again, further restrictions as it moves further south. Just on Friday, last Friday, they announced that they would open what they call the Adre border crossing point, which is another border crossing point. So this, in theory, massively expands access. And what it also does is it gives the UN no excuses anymore, because the UN is saying that they couldn't move supply because Adre was closed. Well, now the government has said Adre is open. In terms of how MSF operates, we've been using Adre since we reopened in Darfur. And we are transparent about our use of it, even though it's formally restricted. The government has no control over this area. And so in practice, you manage that more with the RSF, who are practically in physical control of the territory. But we are transparent in the way we communicate our activities. And we think that the sector should work more along these lines than they are. So the fact that the government announced that people can use it doesn't actually change the physical control over this territory. It's just that now the government is saying that they won't have a problem with it if people start using it. But it also somehow places it back under their purview of like things that they can now manage and be responsible for. So we expect there to be continued problems, major problems with supply, because not only is there all of this obstruction and insecurity for both cross-line or cross-border, but then you also have like the physical issues, like because of flooding, this bridge that connects central and West Darfur is now out. And when they were trying to repair it, SAF bombed the people who were trying to repair it. So we're going to have to figure out now a logistical contingency to this bridge that is now out. So there's many problems everywhere. How do we prioritize then? It's the same way that we prioritize our presence, right? It's around vulnerability and feasibility is how I would put it most simply. It's like what is the most vulnerable needs that we can reach at scale in the most feasible way. So for us, that's a lot of like maternal and child supply. So it's a lot of malnutrition supply. It's prioritizing the movement of vaccines, of safe delivery kits, things like oxytocin. But we try to prioritize the movement of supply and stock based off of the services. And for us, that's mother and child.
Thank you so much for the detailed answer. I have another question that's related to it. As you have mentioned, so this is happening across Sudan, and MSF have been operating in Sudan for a long time. So I believe probably MSF had protocols or a system that worked well in Sudan. How you work with the medical facilities there, how you distribute your medical supplies. I think MSF probably had a process in the past, but currently MSF lack medical supplies and also say some of the infrastructure like the bridges, they are broken down, so it's blocked. I think those things are also happening in an ongoing manner. So my question is that, so this will be probably they're at the top of the crisis. So you mentioned like the bridge has been destructed, maybe some channels are blocked. How do you get those information like currently? How do MSF like gets information about them? Like what's the recent most up-to-date info and how do you get them? So I understand a lot of humanitarian agencies worked in Sudan, but they left more than 1 year ago when the conflict started. And how do you facilitate the information changes in such dire situation?
Yeah, it's with great difficulty a lot of the time. I mean, there's an irony that like in even though, because infrastructure and basic services have been destroyed or otherwise taken offline in a lot of non-government controlled areas, but connectivity has somehow improved relatively more in non-government controlled areas because of Starlink. So we also benefit from, which is not great that the sector is dependent on Starlink, by the way. But that has somehow improved our connectivity. I mean, this is where I think MSF way of working really does stand out compared to the rest of the sector. And you see the meaning, the real value in proximity being one of our operational values, right? Because we place such a premium on having staff there. And sending international staff. And it's not about capacity at that point. It's also just about the kind of mobilization of the organization and the level of resources and attention and care and it's the kind of bandwidth of the organization is then focused on the local environment more so. I think all together with the way that we work and by mobilizing staff into these places. So we, in places where we're working, we like, for example, as an advisor, I have a counterpart in the team, right? So I'm a humanitarian affairs advisor. I have a humanitarian affairs manager who works in the coordination office in Port Sudan. And then we have an officer who's in Niala. So that's kind of my functional line, and I'm in touch with them throughout the day, every day. So that's how I get real-time information. And it's the same for most functional lines, right? That like you, in your job family, you have an advisor that you reach to usually. And so you have a kind of counterpart. And fortunately, with the connectivity, we've been able to stay in better touch with the teams in Darfur and areas outside of government control, because that's where you find more Starlink portals than we do see currently in the East. But it's a challenge, and especially in those early days, it's really hard. Like we found, just to put it in perspective, like the conflict started in April. It took us months or weeks and months to get into real stable contact with our teams in Darfur and Jebel Mara because everything went down. When we finally had teams arrive in January, and when we got in touch with them some months prior to that, we found that with zero contact and zero communication, they had been rationing malnutrition supply and running emergency programs for children in the region without any support from coordination or headquarters. So it also demonstrates the kind of resilience of the teams that we work with, which somehow is missed in a lot of these talks. But yeah, with great difficulty otherwise.
Thank you so much. So you mentioned that you worked with the local staff in the field and you work with them as a counterpart and you update yourself with the current information. During conflict, so I believe there are two sides, SAF and RSF. And I wonder, there are in the conflicted areas, MSF tried to maintain the neutrality, but it doesn't seem like an easy task. So how is it? I wouldn't say it's easy, but how do you maintain neutrality? How do you communicate with the warring parties?
Yeah, it's a good question. I think it's just very transparently, right? And also very simply. Like and I think that this is somehow universal. It's not only for Sudan, right? It's any kind of sensitive engagements with different warring groups or fighters or non-state armed groups in particular. It's kind of relying on principles, speaking very frankly and openly about them. Also telling people that we speak to everybody. Like from the beginning, it's about transparency and making sure that there's some level of awareness amongst the key interlocutors that you have about how MSF works. It's also, I think, about ensuring that we have kind of a real kind of full conception of what neutrality means for us, which can also be rather narrow, right? Neutrality, I think it doesn't, without getting into the debates about like humanitarian resistance and time to eschew neutrality, which you find in the sector, I think neutrality is about not taking the side of a fight, right? Of an actual fight or a political fight, not taking sides, and so I think that if we really keep focused on that being it, we're not. Like, we can still talk about what people are doing wrong. We can talk about the violations of IHL. We can talk about violence against civilians. It doesn't mean we're supporting the other side. And in fact, we can mitigate it by ensuring that we talk about both in some kind of impartial, equal, not that we're drawing equivalence because we don't have the data to do that, but we talk about them in an impartial manner, right? It's really just about what we have. It's just, and by ensuring that we're amplifying the voices of people there on the ground, of patients, then this is us. It's not the organization coming to some kind of determination. It's saying this is what people have told us your fighters have done, and we're able to say that in a much more kind of human grounded way without it becoming a kind of political declaration of support of one opposing side or the other, right? It's just keep it much more human focused.
Yes. To really be impartial and try to fight for the people and to protect their lives. I think that's the core purpose of MSF. And that's how MSF builds trust. I think in terms of treating the wounded, of course, in addition to that, there are other crises like malnutrition, mother and child care, and there are a lot of other difficult situations that you face. So while you carry out relief efforts in Sudan, what do you think are the main challenges that you currently face in carrying out such relief efforts?
Hmm. I mean, it's a bit of a cheating answer, but the main challenge is the fact that it's such kind of a big challenge overall, right? It's the scale. It's the scale of needs is the biggest challenge because it is so many different things. So that's one. And then it's about, maybe more specifically, it's the lack of response. And that relates to access, and that's like more warring party responsibility, but also mobilization, and that's in the sector. So I think the biggest challenge is that, yeah, that it is such a massive crisis, and it's like it's overlapping crises at this point, right? That kind of have a compounding effect on each other, where malnutrition will also affect outbreaks and vice versa, and like it's this kind of multi-layered crisis. And so I think the complexity and the scale is the first challenge. Then it's the lack of meaningful access, and when I say that, I mean it as like assistance reaching people, not the announcements made by the UN or warring parties. So I think those are the two that I focus on.
Yes, and then I think we can probably move on to the last question. I think at the end of last year in Chad, we talked about also the refugee crisis there in our MSF focus series. We did have a question on asking about the current situation in Chad. I think that was also the time that we did have a crisis outbreak in Sudan, but you talked about the issues and challenges with a lot of people being displaced and people on the move were exposed to different types of violence. And in the surrounding countries, what's the current status of the refugees and the displaced people there?
Yeah, I think it's still very difficult. And while I have a minimal regional overlap, more specifically with Ethiopia, so I can't speak in depth to Chad, but yes, suffice to say, of course, there's significant unmet needs there. And this is one of the challenges about funding and kind of coordinating the donor response as well, because then you have funding split between a regional appeal versus a Sudan appeal. That's necessary on some level because it is a regional crisis, but it also makes the kind of inefficiencies of the response then also multiply, right? Because we can't figure out one aspect of it. Now you have to add kind of competing responses that are both dysfunctional in some way. Suffice to say, I mean, I was hearing of like food rations being cut in Chad, like which is crazy because again, like there's ostensibly there's access there. This is where there shouldn't be nearly the kind of excuses. Chad's also a difficult place to work for a lot of its own reasons, right? Logistically, there's only one main road that runs east-west across the country. The political instability, fighting, like there's a lot of things, but nonetheless, they haven't been able to get the humanitarian response like effectively implemented there either. And then, of course, it's a similar story on the South Sudan side of the border, CAR, Ethiopia, Egypt. We hear similar stories everywhere, right? Like, I think a crisis of this scale, we always see inefficiencies in the UN response, but a crisis of this scale really reveals just how insufficient these agencies have become and how unfit for purpose they currently are.
Yes, Kyle, we do understand that you're extremely busy, so we do really appreciate your time and taking time to share your story with MSF today. So, as last parting words, do we have any final comments?
I'll just say thank you for the organization of this event, and also to everybody who has joined. I really appreciate the chance to talk about Sudan. I hope we continue to. I think that somehow that's the beginning of of all of the different kinds of changes that we need to see. In the very first instance, we need to have the attention of the world more focused on Sudan. So I'm very grateful for you making the time, and happy to support any continued discussions as they happen.
Yes, then I guess this now brings our briefing to a close. While the world's attention is focused on Gaza, there are other places around the world that are experiencing extreme humanitarian crises, and Sudan is one of them, as we heard today. We are far away physically from the crisis, and it might seem like it's happening not related to us, but voices together can bring big changes, and it can bring changes that are really required as improvements in Sudan. If you have any other questions of MSF on our recruitment or any other questions, we do have a link that we shared in the chat so that you could look at different information on our hiring information. We do have a session upcoming on September 12th, so please refer to that link. If you have any other questions or any other inquiries into our work or operations, you can also visit our website, msf.org.kr. And we do have a focus satisfaction survey poll. So please also participate here so that we could also improve our focus series. And we look forward to seeing you next time. Thank you very much.